Hi, everyone. Thanks for joining us. I know most of you are still trickling in, but we'll go ahead and get started. And thanks for joining us. Welcome to the Telemedicine Meeting Health Needs in the Age of COVID-19. This webinar is brought to you by the Austin Young Chamber in partnership with Ascension Seton. I'm Caitlin Locke, and I'll be our moderator today. I have the privilege of serving on the board of directors for the Austin Young Chamber, as well as working at Ascension Seton on the strategic implementation team. A little bit more about these two organizations. At the Austin Young Chamber, our vision is for Central Texas to have the most talented, collaborative, and community-focused workforce in the nation. We are focused on equipping young professionals in Central Texas with skills, experiences, and connections to develop dynamic business and community leaders, both today and in the future. And at Ascension Seton, we're a healthcare system with hospitals and clinics serving Central Texas, and with a dedication to spiritually centered holistic care that sustains and improves the health of individuals and communities in Central Texas. Before we begin our presentation today, I've got a couple housekeeping items that I want to cover. This is a live recorded webinar, so we'll send a link to watch today's presentation that will be available to you post-event. And then we'll allow about 10 to 15 minutes at the end for Q&A. So if you think of questions along the way, just submit them in the Q&A box. Should be at the bottom of the Zoom screen here. And I will facilitate asking questions to our speakers at the end. And we'll try to wrap up as close to time at the end, 12 noon. So let me share a little bit more about the genesis of this presentation today. This is the culmination from survey responses for the COVID-19 community survey that the Austin Young Chamber sent out. So this was to better understand and respond to the needs of all of you and our community. A lot of responses asked for resources related to job hunting, skill development, continuing education, and healthcare needs. Specifically from the results, 61% of respondents do not currently feel comfortable going to the doctor for non-COVID-19 health needs, and only 53% of respondents felt they could access COVID-19 related health services if needed. For more information about the survey results and COVID-19 related resources, please head to the Austin Young Chamber website, as well as considering becoming a member today and in the future. I see quite a few of you have hopped into the webinar so far, and so I'd like to get a better sense of who all has joined us, and by starting out with a poll. So you should see it pop up momentarily, and we'd like to get a sense of how many of you have completed a virtual or telemedicine visit in the past, anytime in the last week, 6 months, just so we can see how familiar you are with the topic. And while I'm giving you a few minutes to submit those responses and we can collect the results, I'd like to welcome and introduce our speakers today. First, we have Dr. Amy Apaku. She is the Medical Director for Ascension Connect, Texas, which services virtual care for the Austin community. She is board certified in family medicine and has been working in the field of virtual care since 2017. Ascension Connect houses an entire virtual care team dedicated to providing virtual remote patient monitoring, virtual urgent care, and 24/7 nurse triage. Mark Steiger is an executive lecturer and thought leader in the healthcare IT industry. Currently, Mark is the Director of Operations for the Central Region of Ascension Connect. This spans the entire continuum of patient engagement to create a frictionless consumer experience. Mark has experience in virtual care, population health, patient access, and experience, as well as leading-edge remote clinical surveillance systems and technology. And Dr. Jason Reichenberg is the president of Ascension Medical Group, Texas. This is a multi-specialty group which employs over 900 providers across the state. He is a professor in dermatology at Dell Medical School at the University of Texas at Austin, where his clinical practice and research has focused on autoimmune disease and skin cancer. Thank you all for being here. Before I hand off to Mark to kick us off on the deck today, let's see what the poll results look like. And they should be sharing momentarily. So based on the results, it looks like we're about split. So I think this will be interesting for a great discussion today.
Great, thank you, Caitlin. And yes, that's I'm glad to see that at least half of you had some experience with virtual care, so that can help inform what we discussed today. So let's start by what virtual care is and what telemedicine are. And we do this not because it's important to sort of split hairs over nomenclature, but there is a lot of overlap in the way people use these kinds of terms. And so probably your first foray or your first experience with virtual care or telemedicine was likely on a synchronous video engagement. Think of it like a two-way video or a FaceTime or a Skype engagement with a provider, a clinician or a physician or some other member of the care team. And that certainly is important and a fundamental part of virtual care and telemedicine, and certainly one that Ascension puts a lot of value on and has put a lot of investment in scaling. But virtual care is much bigger than that. And so if you think about any sort of technology-enabled intervention or engagement that you have with a physician or any member of a healthcare team, it goes much bigger than two-way video. And I'll give you an example that probably will resonate with you. Many of you probably have a device on your wrist right now that is measuring stuff related to your healthcare, right? Maybe it's your blood pressure, maybe it's the number of steps you took. Well, so ask yourself, extrapolate that out. There's so much related to technology that we can do in terms of helping ourselves when in both sickness and in wellness related to engagement and measurement and quantification and qualification of data that we've only really just scratched the surface on. I mean, imagine if there were a continuous way to measure, say, vital signs, all of the good that you could do for both prevention and for intervention. And so what are we talking about when we talk about virtual care? We're talking about, yes, two-way video engagements. We're talking about devices that measure things related to your health. We're talking about surveillance into your environment. Maybe that's your home or your workplace or your school. And so at Ascension, we take a very broad approach to all of those kinds of opportunities. And we'll discuss a little bit today what that looks like. So part two of that, though, is why? Why now? What is it about this moment in history that makes this topic so important? And it's because simply there has been a global uptick in the use of virtual care during this unfortunate pandemic. This event certainly has been dire and very tragic, but one small silver lining for advocates of virtual care and telemedicine like myself and like Drs. Reichenberg and Opaku is that there's been a massive adoption of the use of this technology. And the reasons are really threefold. The first is that consumers have demanded it, right? Obviously enough, when there is a stay-at-home order, when there's risk to being in crowds, consumers are going to seek out ways to engage with the healthcare that they need that are different than historically we've done. And so two-way video is one of the most obvious ways to do that. The second is that clinicians and physicians and providers have adopted and become enthusiasts of virtual care. And we all know that the American health education system is the top in the world. And one of the things it does, and does very poignantly and very specifically, is it drills into physicians that patient safety is always the number one priority, and that risk is something they need to be acutely aware of. And that makes sense, right? It's the right thing to do to have physicians always have patient safety as the top of their priority. But one of the things that has done historically is make physicians, some of them, skeptical on whether they can provide the level of care using remote tools or using video in the same way that they could face-to-face. A physician's instinct is to touch and engage and interact with patients physically, and that's the right thing to do. But what that has done historically sometimes is make a discussion around whether I can do this safely with the top quality of care even possible. And so physician adoption has been big in this space. And then the third one may not be one that you as consumers think about, but certainly the three of us think about it all the time, and it's very important. And that is the way that the folks that govern and pay for and guide the way the healthcare industry functions have changed in ways that I could not have conceived of 3 months ago. And what do I mean by that? I mean regulatory agencies at the state and federal level, statutory guidelines related to how and in what ways we can deliver virtual care. And then the whole financial model, the reimbursement model from plans, payers, many of the plans that probably some of you have on your insurance card in your pocket, Medicare, Medicaid, Blue Cross, et cetera, they have changed the way they interact with us as a health system related to virtual care. Let me give you an obvious example. 3 months ago, if you had Medicare, we as a health system would not get reimbursed for an engagement with you over two-way video unless you were in a very specific defined rural area, which none of Central Texas qualifies for. And so what does that do? That forces us as a health system to force you as patients and consumers into face-to-face engagements, even when a video interaction might be just as clinically sound and safe. All of that has been knocked down. In fact, I think, Drs. Reichenberg and Apako and I have been in this space a long time, and I think about the billions that have been spent in the last 20 years on lobbying. And we as advocates essentially got everything we wanted and more in a week in March, which is unbelievable. So the open question then is, will any of that change in a post-COVID or sort of a post-stay-at-home world? And we don't know the answer to that. I suspect as an optimist that there's a bit of a toothpaste out of the tube, genie out of the bottle kind of phenomenon here, where now that we as a health system and Drs. Reichenberg and Apako as physicians have shown that it is safe to use virtual care technology. And now that consumers, many of them, have experienced engaging in their health in different ways, hopefully it's a foregone conclusion. And so we can fundamentally change the way we approach our engagement with you as patients. And so talking about some of the terminology and some of the operational aspects, many health systems, their first sort of foray, first dipping their toe into the pool of virtual care and telemedicine is with a device like you see right there on your screen, and we call it an e-consult. As a hospital system, we think first of how to ensure that patients get what they need in any of our locations, whether it's our level 1 trauma center downtown or some of our smaller hospitals in outlying areas. And one of the ways we can do that really effectively is by bringing a cart like this that has very high resolution video, that has the ability for us to pan and tilt and zoom that camera remotely, that has the ability to add attachments. That's the way that we can extend our geographic reach. And so as an example, a cart like this, if you think back 5 or 10 years ago, the resolution on, say, your phone or a camera that sits on top of your monitor was too choppy, too pixelated, and not high quality enough for us as a health system to treat you safely. Dr. Reichenberg is a dermatologist, and so you can imagine, virtual dermatology requires that I have a very good look at your skin and that the resolution of the video and the picture is of top quality. And 5 or 10 years ago, you needed a big expensive cart like this to be able to do that. Part 2 of that is the attachments. And so this is a real example. If you are a patient at Ascension Seton Lockhart, Ascension Seton Luling, and you need a cardiology consult a year ago, we might have needed to either have you wait for a cardiologist to physically be there, or worse, we might have put you in an ambulance and transferred you up the road to Seton Hayes. Now, what you will do is have a virtual engagement with a cardiologist, and this is where I bring up the attachments. The nurse attaches a stethoscope to this cart. She will manipulate the stethoscope to allow for the hearing of heart and lung sounds. 50 miles away. The physician has noise canceling headphones on, and he can hear your heart and lung sounds exactly the same as he would face to face. And he can also give the nurse direction on moving and manipulating the device. That's just one example. And so the carts are sort of the first foray that most folks took into virtual care. But now, and especially in COVID, the resolution on your phone is of enormous quality. And so there's a lot more that we can do with using small devices like tabletop cameras and phones. And then also we are getting into the space of self-management tools. So as an example with COVID, if you come into one of our EDs and you are symptomatic, or if you maybe have had a test but don't yet have your results, we can ping you via an SMS message to your phone, and it's just a symptom checker. And so every 3 times a day, it will ask you a series of questions that will say, are you short of breath? Do you have a new cough? Those kinds of things. And then it will have you self-input your temperature and your blood oxygen level using a pulse ox machine. And then I have a team of 24/7 nurses that sits in a contact center. Well, no, now they sit at home, but they have a dashboard with hundreds of patients on it. And those patients are turning red and blue and green based on how they respond to those both biometric questions and those questions. You can imagine it's a much more sophisticated way for us to keep a beat on how patients are recovering, and then know if somebody has turned red that we need to escalate right now. And as I said, that's what my 24/7 team is doing. Also, even pre-COVID, but now we have a big use case for remote monitoring. And so at Ascension, if you've had an acute event like congestive heart failure, or maybe a severe COPD, or a pulmonary event, a lung event, we will send you home oftentimes with a kit that has devices in it, a scale, a blood pressure cuff, a glucometer, and a cellular-enabled tablet that every day will ask you a series of questions and will ask you to stand on your scale and apply your blood pressure cuff. Those devices are Bluetooth enabled, and so we are getting a steady stream of vital signs and biometric data and responses to care pathway questions. So again, a nurse with a dashboard will know Mark's doing okay today. He's green, blood pressure is within range, weight hasn't fluctuated, and he has told me he slept well and took his medicine and is not short of breath, and et cetera, et cetera. However, Mr. Jones had a blood pressure spike above our range, and so he has turned red. So I know that I need to get on two-way video and engage with him and potentially, change his medication or provide guidance on social issues, or all of that sort of total range of cross-functional team engagement. Similarly, we talk a lot about, well, is it safe to provide care over two-way video, or is it the same as face-to-face? And in some cases, no. And the easy example is with children. What we get asked all the time is, how do I treat an ear infection over video? And you can't, right? You can't safely, and we would not as a health system. However, with very inexpensive off-the-shelf devices like the device you see here, which is essentially the size of a hockey puck with a guided light and a guided camera, you can attach things to it. And I could say, put a scope on it and place it into my ear. And then Dr. Opaku could get a full view. Wouldn't that be lovely? A full view of the inside of my ear, or my throat, or my nose, or I could hold it to my heart and get my heart sounds. And so you'll start to see the proliferation of these kinds of tools that will make the enhancement of the delivery of virtual care much better, much safer, and will expand for us the number of use cases where we can treat safely. Also, you see kiosks here at Ascension Seton. We're looking at early stages of what this might mean for us as a health system, but the kiosk also can expand the ability to treat patients over video by doing things like having a wand that has a disposable cover that I could place in my ear or down my throat, by having like a vending machine, prescription drugs being dispensed, having a pharmacist come over video and say, you put in your top 75 medications so I could get an examination and get my medications all in the same place. These devices have a floor that is a scale and have a camera that is a thermometer, so I can take my temperature. All those kinds of things you'll start to see in the future, and we as Ascension are wanting to be on the leading edge of that. Also, I mentioned a lot of you probably have a device on your wrist that is measuring something, right? And we get the question all the time, well, why doesn't my doctor want all my, my steps? Why doesn't he want to know how many steps I take every day? And it's not that we don't, it's that we're all as an industry trying to contextualize what part of that is meaningful and what part of that might be just noise. There's a reason that Google acquired Fitbit last fall, right? Austin's own Fitbit. And the reason is not because of their amazing devices, although they are amazing. It's really because of the data, right? Google is a data company, and Fitbit is sitting on a massive amount of data around people's health that we could use to trend and create models and be predictive of the future. And then today, this is might feel a little big brothery, but today you might have something that you can see on your wrist. Tomorrow you might have something that's implanted in you, like a chip or something of that nature that's keeping track of your health. And again, it might sound a little bit dystopian or Orwellian, but on the flip side of that, imagine if you or a loved one could get an alert that says you're 48 hours away from a heart attack and you need to take these 5 steps. I mean, imagine that kind of future, and it's all possible. And so we're looking at stuff like that. And so next, I'm going to hand it over to Dr. Okpaku, who will speak from a physician's perspective and tie in sort of what all of this means from a COVID in the world of COVID and a COVID perspective. So, Dr. Okpaku.
Yes, thanks, Mark. So glad to be with you all today. I'm going to spend a few minutes on the next few slides talking about specific clinical indications when you might use virtual care or when you might not use virtual care, and spend some time on COVID specifically. So as Mark said earlier, there's been a really rapid uptake in virtual care. The demand has been high as everyone has had to stay at home. And so many doctors and systems, including here at Ascension largely, have leveraged virtual care as a service site to improve access to those patients, trying to reduce unnecessary exposure in the waiting rooms and to each other, and try to help patients in their own home. So I was going to review a little bit about what the COVID symptoms are, and this is all updated as of, we reference the CDC as on a regular basis as an Ascension medical group to reference what the symptoms are. And just of note, they may appear 2 to 14 days after exposure to the virus. I think most folks are aware of that now. And the classic ones are cough, shortness of breath, or difficulty breathing. But the CDC has also expanded it to include any of those, so cough, shortness of breath, or difficulty breathing, or 2 of any of these symptoms, which could be chills or repeated shaking with chills, muscle pain, headache, sore throat, and new loss of taste or smell. So there's been several other symptoms that have come out identifying or linked to COVID that the CDC has now recognized as if you have a couple of those symptoms, it might be important to seek medical care. Other things, the most important thing I want to emphasize is if you suspect you have COVID or you've been exposed to COVID or any other urgent care need in general, contact your PCP first, especially post-COVID. A lot of our physicians have become equipped and are ready to go taking care of you virtually. So I would first call your PCP if you have one. And if you don't have a PCP, as Mark mentioned, Ascension does have a symptom checker, which we're going to look at a little bit more closely on the next slide. And then virtual care is another great option in general, as I mentioned, to reduce exposure in the waiting room. So they can help with all kinds of other potentially contagious diseases. The most commonly seen diseases in virtual urgent care, especially right now, we study this where every week we look at the data to see what the top 20 conditions are that were seen from the week prior. And the number 1 condition right now actually seen in virtual urgent care is urinary tract infection, or UTI. Behind that, of course, cough, fever, sinusitis or sinus infection, sore throat or pharyngitis. We see a lot of nausea, vomiting, diarrhea. We see a fair amount of acute skin rashes, so shingles or poison ivy, contact dermatitis, itchy skin, that type of thing. And these things that I mentioned can all be easily handled in virtual urgent care and are routinely handled in virtual urgent care. If you don't mind going next slide. Okay, so taking a look closer, I'm sorry, Mark, if you could go back 1 slide. Thank you. Okay, so this is the slide that's the symptom checker that Ascension has available that Mark mentioned before. What I want to mention on this slide is just a note about children with COVID. Children have very similar symptoms to adult, but they're much milder. And that the other thing, when a patient might want to seek medical care more urgently, is if they have certain comorbidities. They ideally should check with their PCP first for an opinion, or be seen in person if needed. Not necessarily, but they're a little bit higher risk to have worsening symptoms of COVID in particular. And these chronic diseases include diabetes, chronic obstructive pulmonary disease or COPD, any other lung disease, smokers, and then heart disease has also been identified as a comorbidity that increases someone's severity of COVID. So heart disease could be a prior heart attack or congestive heart failure. And then, of course, we always advise all of our clinicians and patients in general that there's certain symptoms that you're going to call 911 or just go straight to the emergency room. And these include severe chest pain, shortness of breath, severe shortness of breath, blue lips or any signs of apnea. And then the other thing that the CDC has recommended straight to the emergency room is any new confusion or delirium, which we would, that's even pre-COVID. And so this self-checker will help you, guide you if testing is indicated and where to go. So this is Ascension's tool. The CDC and Ascension recommends based on priority groups. So some of these will help stratify for you. And then I think, Mark, if you don't mind for the next slide. Yeah, so talking about when should someone be seen in person and when could they be seen virtually? So we're just going to outline this a little bit more specifically, specific conditions. So as I mentioned, virtual care, you can use acute or for urgent care needs, specifically urinary tract infection, like I mentioned, cough, skin rash, sinus infections, sore throats, those types of things are all reasonable reasons to pursue virtual urgent care. For when we're talking about a chronic disease follow-up or a primary care follow-up, then this virtual care serves a purpose when you're trying to fill in gaps of care or in patients that you know really well and you want to see them virtually in between of their scheduled in-person visits. So examples of this might be someone who has very stable diabetes, ADHD or attention deficit hyperactivity disorder, or just ADD, stable depression for medication refills, stable thyroid refills for low thyroids, and then also for lab or pathology review. So specifically if these are normal pathology results, so let's say someone had a colonoscopy and they want to just discuss this with their provider but don't want to have to come into the office, or similarly for a lab review. So these are all great use cases for virtual care for a chronic disease or a PCP environment. Also limited access, of course, so in Texas, outside of the greater Austin area or central Texas in our rural areas, and then, of course, especially for medication refills, because we would much rather fill those medications with a virtual visit than have them go without and wind up in the emergency room. Similarly, this could be for specialty access if the specialist is in one location and the patients are in rural locations. And I think Jason's going to talk a little bit more about that in the coming slides. And then patient education, this is an incredible use case and something that we're using actively right now. Ascension Connect, but specifically for diabetes education, nutrition counseling, behavioral health, tobacco cessation, weight loss, all of those are great use cases. So whenever you have to go into the office, so when is it that you would say virtual care is not appropriate? And definitely when there's a hands-on diagnosis or evaluation that needs to happen. So an annual physical exam, unstable diabetes, maybe you need to do a foot check or you need to do a neuro exam, those types of things. A new wound, if you need any kind of skin procedures, so incision and drainage, new trauma. So if you fell and possibly broke your wrist, you need to be seen to get that examined, possibly splinted, maybe some x-rays orders, those are all. So one of the best models for virtual care actually looks like a hybrid model in the established patient. And then my last slide, this is kind of similar to what Mark was discussing, but it discusses the different, I guess, definitions or times when you would use virtual care. So urgent care, as we talked about, now no appointment is necessary. This is instant access. This is 24/7. And so Ascension Online Care is the virtual urgent care that that's our service for that. So that's 24/7. You just go right into the waiting room and you're seen by a provider virtually for urgent care needs. For PCPs, that this does need to be scheduled. It is dependent on your physician's guidance and their whether or not they're accepting virtual care, how they're doing virtual care. And Ascension Medical Group is doing this very actively right now. And then, of course, the specialists. So this also depends on the physician, how they're set up. So you'll want to contact them. So for instance, Dr. Reichenberg and his dermatology practice or a cardiology practice. As Mark mentioned, of course, there's several other ways that you can practice virtual care. There's remote monitoring. There's the other thing you may hear is synchronous and asynchronous. So synchronous is a live, secured, HIPAA compliant audio video connection, and then asynchronous is a kind of a store and forward, which Dr. Reichenberg might mention, because that's very relevant to his field in dermatology. That's when you might take a picture of your skin and upload it, have your physician evaluate it, and then get back to you. So I'm going to hand it over to Dr. Reichenberg right now.
Thanks, Dr. Crocker.
Yeah.
So, I would say that the good news with all this, as Mark said, is that we're getting huge strides into telemedicine. So right when COVID hit, I think everybody's first reaction was to stop doing anything that was non-urgent. So many non-urgent follow-up appointments or non-urgent annual checks, a skin check, for example, we called those patients and we said, hey, we're going to hold off for a few weeks unless it's urgent, and we'll see you a little bit later. Then, as we've learned, COVID is not just going away. We didn't have a small spike and now we're back to normal. I think we're realizing that for at least a while, for at least a few more months, COVID is going to be around. And so just like many businesses are starting to go back to business, what our medical group has done, and I know that other medical groups have done similar things, is we've created a strategy around how to make sure to see patients back. So at the height of the COVID crisis that we had in Austin, where everything was shut down, we were still seeing about 900 patients a day in person due to urgency and things like that. But we were seeing where before the epidemic, we were doing about 60 virtual visits a day. Now we're doing on average 1,500 to 1,600 virtual visits every single day. A huge difference. But we are realizing that we do need to start seeing those patients back. I do need to do my annual skin checks. You do need to have your wound checked or your feet examined for diabetes, or your heart listened to. So what we've done in our offices is create a protocol, a safety evaluation, and I've been participating in a lot of these. We have 160 offices, and we sort of created a checklist of all the things that we expect every practice should do to protect a patient from themselves from getting exposed to COVID from another patient, protecting our staff from getting exposed to a COVID patient, protecting a patient to get exposed from a possible staff member with COVID, and to make sure that we're following all of our normal guidelines and trying to bring patients back safely. So we do a lot now about screening patients beforehand, limiting how many visitors we have. We limit the number of people in a waiting room. And in fact, in a lot of our offices, you'll actually be asked to wait in your car, and then we'll just text you and tell you to come in. We're making sure that we're cleaning between patients and we're wearing the appropriate equipment. So a lot of work done. You can imagine some specialties need a lot more attention to protecting people. For example, I spent last night with our oral surgeons, where people's mouths are open and there's saliva out there. Well, we work really hard. We spend hours and hours thinking through how to make sure to see those patients back safely, keeping other patients protected. Where you have other groups like psychiatry, for example, the joke I keep on telling everybody, we're actually seeing more patients now per day than we've ever seen in our history in Ascension, because nobody has no shows. Everybody just shows up. All of our psychiatry patients are happy. We're not working as quickly to get everybody back because there doesn't seem to be as urgent of a need. So back to business is really one of our first strategies there. Mark, we can go to the next slide. What we're also realizing is that, as Amy pointed out, we can only do so much virtually. So if I see you virtually and I decide that you need to be swabbed for COVID, for example, right now the option is for me to tell you to leave your house and to go get a COVID swab at one of our drive-through testing centers, which is fairly convenient. But our next step is to see, well, what else could we do to allow a patient to remain in their home? For example, we had many patients who said, I don't mind coming to get the test, but then I would need a babysitter for my kids. Or I actually don't feel comfortable going outside or driving or one of these things. Is there anything we can do? So our next step, and we actually rolled it out just this week, is offering laboratory and other services at patient's home with a van. So we found, for example, our first clinical need is we had a huge backlog of medically necessary orthopedic surgery that we needed to do in the Georgetown Round Rock area. We had a very big orthopedic practice, a lot of patients with pain who needed to get their surgeries done, and they all need COVID testing or blood testing or things like that before their surgery. So we have put together our van, which ironically used to be used to go to sporting events to provide medical care. Well, right now there are not a lot of sporting events happening in Texas, so we quickly repurposed that van to do COVID testing in patients' houses. We're going to hopefully soon get to the point where if Dr. Upaku sees you for your pediatric annual visit, she can do a lot of her annual visits with the kids, but there's just a few steps that she can't. She can't get their weight, she can't get them an annual immunization. Well, maybe we can get that done in the van, and then you can imagine the van pulling up, doing 2-3 kids at once, and letting the parents go back to what they were doing. So we're continuing to think about how to expand those services, currently offering it as of today in Georgetown and Round Rock. I believe next week we're going to be opening up in Waco, where's the next largest need. And then we're hoping after that to open something up in central Austin where the van can go to patients' houses. So this is a pilot. We're trying to see if it works out for the patients and for the staff. Next slide. So what we wanted to talk through some scenarios, and really what I'd love to do is even hear if we have differences of opinions about how to approach things. So we're going to start with back and joint pain. So I'm going to give a scenario, and actually I'm going to spin it to Dr. Upaku to see where she would suggest we go first. So I'm going to say that I sprained my ankle. I went on my first walk that I've gone in the community, and I tripped over a step that I forgot was there, and my ankle is sore, and I don't know what I'm supposed to do. So how would you approach that with telemedicine, Dr. Upaku?
So great question. So I would ask a lot of questions around there's Ottawa rules for whether or not you should get X-ray of that ankle to evaluate for a fracture. So I would use as many questions as I could without being able to examine the patient to try to, like, can you walk on it? Can you touch this particular part of your ankle and tell me if you have pain? And if there were some signs that were positives for the Ottawa rules, then I would probably suggest that they go into an urgent care for some imaging and maybe get some crutches, those types of things. If they didn't have any of those pertinent positives for the Ottawa rules, then I would take a look at the degree of swelling. I would ask someone within their home to actually assist me with a range of motion and strength exam and focus the camera on them. And then I would try conservative therapy with rice, and then follow up with them in a couple.
Excellent. Well, I'm glad that I'm done, as I would not have done a good exam there. But I love the idea of having another family member participate in your exam to help to see about that. I was trying to show range of motion without putting my leg up in the air. But range of motion meaning how much can they bend or weight there on it. The other thing we've learned from an orthopedic surgeon, we had one orthopedic surgeon who had a similar scenario last week who admittedly, after her scenario, wanted to get hands-on. She didn't necessarily need an X-ray, but she needed hands-on. So she actually checked in the patient to the office, did all of the pre-visit stuff, took insurance, got her medication lists done, and then generally just had the patient drive up to the office. The orthopedic surgeon ran out, and she actually did the assessment in the patient's car, realized very quickly that she was okay. As you said, a lot of times these are just sprained ankles, and then was able to let the patient leave. And she could do the follow-up visit with education over the phone or via video. So even if it couldn't be completely virtual, she was able to limit the on-site visit so quickly that it was just really convenient for the patient and the provider. So I'll talk about skin cancer. So now I'm going to talk about what's called store and forward technology. So I'm going to admit to you that despite our best efforts right now, most two-way video chat, including probably the chat we're all having now, is not perfectly viewed. So, I mean, I'm going to put my arm up there. Maybe you can delineate some of the hair on my arm. I don't have any freckles on that hand. Let's see if I can find a freckle. Maybe you can see a little freckle there, but there's no way for you to get a really good view. What I'm finding is that if I can have, especially have a family member, take a picture with their phone, same phone, but off of video mode onto camera mode, and email that picture to my office in a protected email drive, then when we do our virtual visit, I can actually give recommendations. What I'm finding actually is similar to the analogy I gave before. I would say that about 30 to 50% of the time, the patients actually were fine. I can tell what it is, and I don't need to see them. So that was considered what a store and forward visit. So I got the email, and then I was able to send them a message saying that spot does not seem like of concern. You don't need to come in. But I would say a solid 50% of the time, my patients knew what to look for. I have a lot of older patients. And then we do the same thing. We bring them in for a very quick visit where we do a quick biopsy and we let them leave. Respiratory, what I was hoping that you can do a little bit, Dr. Opako, is talk about maybe somebody, maybe not even respiratory, maybe somebody with CHF. So I have an elderly grandmother who has heart failure issues. She's having some problems breathing. She has seen you in the past. And how would you approach her? Because as you can imagine, I mean, there might be things you need to know about her that you can't just assess with visual two-way. How could you address that? Maybe some other tools that you might have in your chest there.
Yeah, so heart failure is something that we see quite a bit of through the remote patient monitoring. So this is a patient that is established with me, is that correct? So I've seen her before in the office. Yeah, okay. Yeah, so yes. What I would do is, of course, the very first thing all of our providers do at the start of any visit is be sure the patient's not in acute distress. So are they able to complete full sentences with when they're usually able to complete full sentences? And that's actually your first indicator if they have to stop and take breaths, that the patient is more acutely ill or dyspneic, which is very short of breath. The next step, number 2, that every single one of our providers does, no matter what the medical chart says, we of course would be reviewing the medical chart that we have, but I double check their medications, and specifically for our heart failure medications. Are they taking their beta blocker? Are they taking their Lasix or their diuretic? Did they miss a dose? Do they have a very salty meal? Do they have a scale? Can they get on it? Can we check to see what their baseline weight is? The other trick that I do quite a bit is I'll ask patients, what is the furthest place in your home where you are right now? That may be the front door, that may be up the stairs. I want you to go there and come back. And I wait for them to go their furthest distance and come back. So a lot of heart failure is a symptomatic, it tells you there's symptoms of how short of breath when they come back to that furthest distance, tells you if their heart is pumping harder and having a harder time because they have more fluid in their system. At that time, if I know the patient and they're on Lasix, I'm going to increase the dose or add a few extra doses for a few days. And or we, as a PCP, we usually call the cardiology office and just talk with the cardiologist or the head nurse there and just notify them, let them know what we're thinking about doing, which is increasing the Lasix for a few days. And then again, a very close interval follow-up. Now, there's certain signs, again, if they can't complete full sentences or they have belly swelling, those types of things, I'm going to have a lower threshold to actually send them into their cardiology office or to the emergency room for evaluation. But we try hard not to do that.
Dr. Opako, just one question. Lori LaChance asked a question that maybe you can help to address. So we have, I know you talked about mobile monitoring. We have the ability, if I'm correct, you can actually send a patient home with an oxygen monitor that they can monitor themselves, correct?
Correct.
So you have a scale that you
Yes.
can send home. You have an oxygen
Correct.
monitor. You probably even have a blood pressure cuff you could check, mm-hmm. right? So I know this sort
yes.
of second part of...
Yes, and a pulse.
Excellent, excellent. So the second part of her question is, would we provide it versus purchasing it? Lori, I think that might depend. I hate to be cynical. It may depend on the financials of this. So for example, a lot of our chronic heart failure patients are patients who unfortunately are very high risk for going into the hospital. And for those patients, we have such an incentive to keep those patients out that the hospital system is happy to send them home with a all expenses paid scale, oxygen monitor, et cetera. where for other conditions or in other scenarios, right now, it may be that we actually ask the patients to purchase it. I know that one of my providers had just pitched this week that we try to offer at least a link onto Amazon to show people where to buy equipment if they want to, or offer to ship it from Ascension. And I genuinely have no idea what the logistics are. So the sale of equipment is a whole regulated thing. So we really would have to decide if we're going to provide it for free, and it may be worth it. So at an at-risk model, if you are in an insurance plan in which the provider is at risk, anytime you go to the hospital, the provider wants to keep you out. And I hate to be cynical, but this is how it works. Where if I'm just being paid for every time I see you, and you end up in the hospital, and unfortunately there are insurance plans like that as well. In those plans, they may ask the patient to pay for it themselves. For me, I think it's less important about that. The more important thing is that we start learning how to do this and do it right. As Dr. Upaku talked about, she leads a whole team of people who do this home monitoring. This is not a doctor-led only thing. A doctor is not every day doing it. It's about leveraging nurse practitioners, nurses, technology to highlight code red, code yellow, code green, so that Dr. Upaku can quickly skim an entire list of people without feeling like he has to go through it. And in that way, Dr. Upaku can handle a lot more patients and still get them the hand-on attention that they need. So I think that that's the more important part, is making sure we are using those tools. I'm glad to defer the next question to Mark or Amy. I don't know, Mark, are there more slides for me? I think that might be my last slide. Oh, yeah, well, this is sort of what we're talking about. So I'm okay. Amy or Mark, do you want to answer the questions about, I don't know if you can read it. It says, what efforts have been done to support rural clinics and hospital partners? How is payment done for telemedicine? I'm glad to defer to you guys, or I'm glad to kick in.
Yeah, so extending our reach as a health system is, you're spot on, whoever asked that question, related to how we expand our ability to connect both in rural settings.
Need to change at some point, but very exciting that they're offering more access, so those rural clinics can continue to offer some level of service to their patients who really truly don't have anything right now.
It's a great point for a mission-driven nonprofit organization that's committed to serving the poor and vulnerable, which Ascension Seton is. Sometimes in this space, there is a misperception that virtual care is only a tool for the rich, or that there's some sort of divide in the population's ability to access these services only if you can afford it. And it's actually just the opposite. Reaching the vulnerable and the underserved is made easier with technology. And in fact, what you do is you knock down some of those barriers that those populations sometimes prevent them from accessing care, like the ability to take off work, like transportation insecurity or housing insecurity. I mean, imagine, if you don't have the ability to take a day off to go to the doctor, but you do get a lunch break, I could go sit in my car and get the same quality care and get a prescription sent electronically and not jeopardize either my employment or my ability to access childcare, all of those kinds of things. So we get very innovative in those public spaces and those populations that are at risk. Using technology, it's actually the opposite of sort of a population divide.
I'll just piggyback on that, Mark. It reminded me of a patient of mine that had high blood pressure, and the only time I could see him is on his lunch break in his car. So we talked several days in a row when he was in his uniform and on his lunch break in his car. So the idea is really to extend the reach more than anything else. We've had community health paramedics similarly tell us that they're some of the only people that have the trust to go into some of the homeless camps in our area. And so we've brainstormed around, what if we equipped them with a tablet, and how much further could we go with this instead of having that population unfortunately wind up in the ER for things like medications and that type of thing. So yeah, it's a passion of mine for sure.
We had two questions come up on the Q&A tab. One, I believe we answered about how do people buy tools for some of these home monitoring. The other question that Christanne asked was what kind of new services have begun to exist beside what the health plans cover? I'm going to try to answer it in the best way I can. I would say that as we learn that, especially in states, and I'd say Texas is not one of those states, in states in which the majority of health is considered capitated, meaning that the provider's team are at risk for everything that happens, for example, in Massachusetts, the definition of things that are covered in a health plan completely changes. So in Massachusetts, for example, where most of the plans are at risk, they're providing all sorts of things. They're providing taxi fare. They're providing some of these tablets. They're actually sending tablets to patients' houses because these are things that will keep the patients out of the hospital. The taxi ride for when they need to, they've provided sometimes food assistance. And these are things that I think it depends on the business environment. Since you guys are a chamber of commerce, you'll appreciate. It really depends a little bit on the business environment. You have a business like Whole Foods that we have worked with in the past. They provide all sorts of on-site nutritional counseling, which is not something that normally insurance plans wouldn't provide. They provide some exercise. I know of health plans that reimburse for gym membership now that they hadn't before. So I really think that if we start thinking about health as a larger problem, you're going to see a lot more things might be covered as a way to bring patients back to what they need. This is definitely good for Opaku. Dr. Hamilton, one of our docs, asked, I've read that there's a high rate of antibiotic prescribing with telemedicine visits. How can this be addressed?
Yeah, so this is a very timely and great question. This is actually something that I do on a regular basis through our newsletter. So we have a urgent care newsletter that goes out every week, and I look every single week at the top 20 medications, and I'm collaborating with, there's a whole team for Ascension Medical Group on a national level that looks at this as well. So I'm working with that group, and then we're actually going to stand up a separate committee on looking at antimicrobial stewardship. So we are very aware of it. We are very active in directly reaching our providers. So in this newsletter every week, I am listing specifically what those medications are, and we're going to start discussing antimicrobial stewardship on a weekly basis. So we are looking at that very closely, yes, and working on it very, very closely. Does that answer your question? Or, hopefully.
So we had a question here that Dr. Opaku and I both actually know something about here. This technology opens up possibilities with our growing aging population and the ability to age in place. And I think that we've already talked about how to do home monitoring and how that really can prevent patients from ending up in the hospital. I have several patients who we sort of have committed, me and the patient, we're going to keep you out of the hospital, whatever we need to do. And we call all their doctors and their teams. I think care management is something that telemedicine really could help with. If you think of the idea of right now, I can see a patient by myself. I've actually had a third party enter in. I've had a wound care doctor join me in the same visit so that we can work to keep this person at home. Another way that this happens is there are services. For example, there's a company out there called Iris Plans that'll offer to do end-of-life counseling as far as making sure that patients have their living will set up. They have all the legal care that they need to sort of protect them from feeling like they're ending up in a hospital and they don't know. They've had those difficult conversations at home with the family members all Skyped in from different locations. So I completely agree. I think that I'm hoping that in the next few years, hopefully, I'm hoping by the time that I get to be aging in a home, there are a lot more resources available there. And then Dr. Zamora mentioned that there's a lot of data that's coming out of this to support clinicians. Are we studying the data from COVID to provide insight? I don't know if Mark, you've been talking, I know Ryan Leslie and I were talking about that a lot the other day.
Yeah, as Dr. Opaku mentioned, we certainly are looking at both outcomes as well as what consumers are interested in, what patients are wanting to use telemedicine for. And so one of the things as a quality-driven health system that we're committed to is ensuring that we are not providing unnecessary care or driving up the cost of care. And so we look at whether or not the outcomes are or where we want them to be, or they're of same quality as a face-to-face intervention. You know, one thing I measure with remote monitoring, there's a phenomenon in healthcare called readmissions, right? Where you might have been in one of our hospitals and you leave and then you come back within, say, 30 or 90 days. And what that means is we haven't done a good enough job to bridge your care back into the outpatient and home environment. We don't want a readmission, right? We want to be able to give patients the tools to be able to manage their health and not bounce back. And so with remote monitoring, Dr. Opaco and I measure that readmission rate, and it's much, much lower for a patient who gets those daily interventions from us, as you would expect, right? Because we can catch things much earlier than if you had a high blood pressure that went on for months and months and then resulted in a very acute event where you were in our ERs, versus we caught it on the first day it spiked, we changed your medication, we gave you a dietitian, nutritionist appointment on how to eat better, all that kind of stuff, but improves both quality and reduces the cost of care.
Let's go to the last two slides to finish up here. Yeah, this is just my bragging slide. This is how many telemedicine visits we've done in the Ascension Medical Group. So you can see that in March, we did 39,000 in-person visits. We did 25,000 virtual visits in April. Actually, I think it was about 32,000. So huge change over the past 2 months in the number of virtual visits. And our hope is that as we start offering more in-person visits, the virtual visits stay. That this is not becoming an and/or, but an and. And then the last slide. Yeah, so I would just say if you're interested in virtual care, certainly within the medical group, within Ascension, we're very much on board. I think a lot of the other providers in town are looking into these options. I think it's important to advocate for yourself and ask your provider, hey, can I do this virtually? Do you offer that as a virtual option? Definitely agree that technology is going to help us a lot. And I think Dr. Opaco's team is really the key of trying to keep patients well. So I take care of patients when they get sick. Dr. Opaco's job is to keep patients doing well, which is awesome. I didn't know if Dr. Opaco, you had any other closing comments before we end.
No, I mean, I think just in general, this is just the tip of the iceberg. There's so many things that could be done with virtual care, and with the overarching goal of keeping patients well and safe. So that is our mission, is to keep them in their homes as much as possible and safe, and add this as another tool in your doctor's toolbox. So it's just another option. So hopefully will increase compliance so that patients aren't driving 2 hours across town and taking a day off of work for their follow-up visit. So this is just the beginning.
Awesome. Thank you all for closing this presentation out. I even learned a lot, so I'm sure our entire guests did as well. And we're right at the top of the hour at noon, and we sprinkled in our questions along the way. So we'll wrap up now, and I just want to close to say thank you to all of our speakers, Dr. Opaco, Dr. Reichenberg, and Mark. Thank you so much for sharing your thoughts and ideas today. And I'm excited to see where telemedicine goes from here. And then to all of our members and guests, thank you so much for joining us. Please remember to keep an eye on the Austin Young Chamber website, austinyc.org, for any future events, and stay safe and stay healthy, everyone.